So thank you. Yesterday we sort of have been talking about the 1990s and an increasing number of uninsured at a time when there were recurrent recessions related to global flattening of economic markets, where a lot of folks lost jobs and a lot of folks are entering the gig economy. Less large employers were providing health insurance. They were not required to at that juncture. There was no laws to mandate that. What this all precedes is the lead up to the efforts by the Clintons to create a national health insurance and the failed efforts that ensued. And did we look at this slide yesterday, the policy trap? Does that people remember this? I'm going to go over this again. Well, the policy trap, and this is from Paul Starr, basically is if you have a strong economy, and that the majority of folks who are voting are satisfied with an adequate health insurance. If you have, and that's among younger people who have employee-sponsored insurance, or you have seniors who have affordable insurance via Medicare. If you have a majority essentially of constituents who are satisfied with their care, that's all you need to do to not create reform to cover and improve a health program. This policy trap refers to creating and funding um, a very complicated system, a deliberately and increasingly complicated system that satisfies enough of the voting public and enriches industry and lobbyists as to ensure that change is difficult. One of the ways that the system is complicated is by doing opaque tax funding of employee-sponsored insurance. So a lot of the public doesn't realize that employers get huge tax breaks for providing healthcare. That's a good thing. It incents them, but it's still their tax dollar that is used for a commercial insurance endeavor. People don't recognize today how public revenues, our tax health dollars, are diverted to profit within Medicare Advantage. You're going to hear that on a number of occasions. So when a system becomes complicated, oh, it's too difficult to understand, I can't go there. Again, it also helps to discourage people from insisting on saving their tax dollars towards better health care. Does that make sense in terms of the policy trap? And that exists to this date, and it's part of the scheme of the American health insurance industry to maintain profit. And that sounds pretty cold and bleak, but it's the reality. You'll hear that from Wendell Potter, who's going to be speaking to you guys later, who's a terrific speaker. So the 1990s brought about senior Bush's defeat to Bill Clinton, in 92. And of interest, Hillary Clinton's a very bright woman. She has a lot of experience in the world of agencies and health policy. Politically, he may have made a mistake by appointing her ahead of the national health insurance endeavor. So she was appointed as the director of the Health Security Act's design. Again, this is going to sound familiar. It was the same efforts that Harry Truman had in 45, and it was an ambitious act to create mandatory enrollment, to create community ratings so that premiums were affordable and inexpensive. It was to be universal for all citizens. It had as part of its process eliminating pre-existing conditions, full drug coverage. One of its other issues as a acquiescence to politics was to have it administered via regional associations as Medicaid is administered. And again, we've seen that in Germany, we've seen that in Britain, where there are pre-existing sickness funds, for instance, that were used to do administration. The problem here in the US is we have huge partisan discrepancies between states and their outlooks on the role of government. So that was going to create a problem right at the offset. Without doubt, the American health insurers programs were clearly opposed to this, as was the American Hospital Association, less so. Um, um, in the mid-1990s, the American hospitals were struggling in their negotiations with the health insurance industry. So it was less of a opposition on the basis of that stakeholder. However, politics being as they are, the public was dissuaded by some really terrific commercials. Again, before your time, but they had these kitchen table commercials where the husband was speaking to the wife about just this is too complicated. It's 300 pages. How can we possibly get through this? Our taxes are too high already, etc. It was very well designed. It was dead on arrival and did not pass. So again, how are people covered? So not everyone had insurance. There was these state high-risk pools that existed throughout the country, typically through a state's insurance agency would designate these. They were not affordable for the vast majority of people to pay into them, and they only covered 200,000 people in 34 states. There was a lot more people who were dealing with catastrophic health costs. That wasn't, but it was touted as the solution, by the way. The reason I bring that up is I heard politicians saying, "Oh, we have coverage for the uninsured." In reality, we did not. In 97, what was accomplished was the Balanced Budget Act, which included S-chip. So this is funding to expand Medicaid for kids whose families could not afford health insurance, but were not provided Medicaid because their income levels were above the federal poverty level. Federal poverty level being 137% of what was considered the poverty line. So there are many families and many children whose parents were making a little bit more than that, but had no health insurance. S-chip actually was successful. It established in a variety of ways and as connected with Medicaid, care for 7.5 million children. And that remains the case today. That's not a trivial number. So these things were happening. Again, what was happening during this time is you have a graph here of the cost of health insurance premiums between 99 and 2008, together with workers' earnings and overall inflation. Overall inflation at that juncture was relatively normal at 30%. Workers' earnings were barely keeping up with it, but they could not keep up with the cost of health premiums. And many economists make this point recurrently that the amount of monies that are expended by the worker towards their health premiums would be money that otherwise that would be going into their pocket to help the overall economy, to help them purchase things, buy homes and buy conveniences, if they weren't going to health premiums. Again, here's a graph. We're going to see this again. At the top of this graph is what it would cost a single person who did not have a family. In the light blue is what it would cost a family on the whole to provide healthcare insurance. It went up from $6,000 in 1999, doubled by 2011, more than doubled by 2011 to 15,000. This is the way above the cost of inflation. Again, as we've discussed, there's sea changes in terms of how hospitals maintain their solvency in the face of powerful insurance companies. What the hospitals needed to do is they consolidated. You're going to have, by the way, many of the questions you asked will have specific lectures later in this series around. You're going to have lectures from Dr. Verhoff, a current president of PNHP, around hospitals and hospital funding. But I'll just briefly mention that hospitals decided if they could consolidate, they could have larger markets by which they can command negotiations and insist that they are able to have increased remuneration for the services. So the handcuffs that the insurance companies were putting on were actually removed, and hospitals actually became more successful in these negotiations and in raising everybody's healthcare as a consequence. So this is just other issues. These will be on your slides. But it was a time that we did clearly see more physicians and allied clinicians employed by health systems. And here's a statistic that again was raised during some of the previous discussions on primary care. In 2012, that says 5.6% of US doctors were hospital employees. I don't think that's right. I think it was about 10%. But by 2022 it was 52%. So huge, that's a huge sea change in terms of the medical profession. This is a fake chart. I'm delighted that I'm the first one who gets to present this to you, because this is such an interesting chart and such fun to show you the statistics. I think Norelle asked a question about, or someone asked a question about administrative costs and waste of the healthcare dollar in the United States. Remember, we talked about diagnostic related groups in an effort to put a restraint on costs in Medicare that happened in around 1985 or so. We started to see a climb in the number of hospital administrators who were doing the diagnostic groups, trying to upcode diagnostic groups so hospitals could be reimbursed more in those buckets and bundles of care for a diagnosis. What happened in the 1990s is the American health insurance companies, these managed care organizations, took off. So so very quickly they were maintaining the majority of our health insurance if you were not on Medicare. So the number of managers now responsible for taking care of those prior authorizations for doing those diagnostic tests. This was not DRG. This is interfacing with the private corporate industries providing healthcare. That's what resulted in this explosion. We've seen more of an explosion now with Medicare Advantage. And this is not just happening in hospitals, this is happening in health, in doctors' offices and practices. You see the number of physicians and the little yellow strip on the bottom. So I think this is a striking example of what was going on. So we're going to see more slides on this, but in addition to premiums going up, in addition to the cost of hospital services going up, in addition to the administrative waste, our prices were going up. And the major reason for these high costs were two things. If you're to learn anything from the stuff I'm presenting to you, there are two things that really cost. When you see the charts of American healthcare exceeding any other nation on earth, two things really result in that. It's the waste of the healthcare dollar that's actually not going towards healthcare, and it's the prices of the services that we provide. It's not that we're doing more services, and we'll show you many illustrations of that. It's not that our population is older. Our population is younger than many European countries and certainly Japan. It's not that we're doing more MRIs. Yes, we do some more of some services, but it's not accounting for this. So there are numerous studies that demonstrate we're exceeding $600 billion and probably more than that, depending on how you account for administrative expense. That's on an annual basis. That's not over a decade. $600 billion yearly. So we discussed about the administrative costs at a hospital and every physician's practice, perhaps not Dr. Cunningham's as a direct payer clinician, but the vast majority of practices are spending huge amounts of money. And we'll talk about that, I think. Whoops, let me go back. And any guess, now that I've shown you the slide, do I have any guesses from you about how much the average practice would spend on hiring the people to do the interactions for getting prior approval for change on a drug off a formulary, for getting the various diagnostic tests, and for the other coverage issues, for the billing and the like? Any guess on how much that costs an average practice on an annual basis? Go ahead, Kaya.
On an annual basis.
Annual.
I don't I'm just based off of the wages I know to hospital administrators to make, it has to be over $1 million, right?
No, no, I'm not talking about a health system. That is for sure. For a health system like Dartmouth, I mean, it's more than that, of course. I'm talking about a practice of three primary care docs on an annual basis.
Oh, I don't know then.
Any guesses? Let's throw out a number.
I'll say 300,000, maybe about 100,000 per physician.
And that's about right. So about $100,000 for a small practice per year. And that was as of 19, that was as of about 10 years ago, probably more now. So if you think about that implication for every practice in this country, we're getting into some big bucks. This is again a slide that Dr. Singh presented. This is from PNHP. I think this is a striking slide. Duke Medical Center, 1,000 beds, 1,600 billing clerks. University of Toronto, 1,200 beds, 7 billing clerks. There are many studies over the years that demonstrate this. So it's a problem. Um, and again, some of the costs are also on the basis of the private insurers. They are hiring these utilization review teams, managers, directors, and basically restricting of care or approving care. That's not to mention the marketing and the advertising and what they pay brokers to push their insurance. But each one of the private insurers is taking what goes in the premium towards profit, towards maximizing their competition with their colleagues. That's a good thing if it's not taking monies away from healthcare, but it's coming from the same healthcare dollar, the premium that's spent for one's insurance. So these administrative costs vary. We've talked about for-profit managed care organizations that also are now managing care and Medicare Advantage. Their overall administrative costs, which includes profit, is anywhere between 18 and 20% on average. The non-for-profit managed care organizations, of which there are many, is about 10%. There's this Connecticut, the state of Connecticut, that has all these insurance companies. It's the most dense number of insurers per population. They elected to take managed Medicare, so managed Medicaid, which is your tax dollars being managed by a private managed care organization, supposedly for efficiency. They took it back, decided to do state administration. They dropped their costs from what was about 10% in their instance to 3%. And that's the same thing for traditional Medicare. It's about 3% in overall administrative costs. Again, in terms of just we do want to cover a few things today. What was happening with hospital prices? Again, Medicare as a single payer is able to restrict service costs a little bit better than other groups. So in terms of overall expenditures, hospitals were climbing the highest in terms of prices, but Medicare was able to keep down those prices the best. I'm going to skip through this slide. We've sort of talked about this already. Essentially, this is just talking about how hospitals began to command higher prices for their services as they consolidated. It's just that, and as they sought those high revenue services. This chart, again, does represent that as well. This is basically showing the charge to cost ratio of average services in a hospital. So what, in other words, it costs me $3,000 to keep the lights on in the OR and to provide the salaries for the OR nurses to provide an appendectomy. So I will charge a certain amount over that to sustain a revenue, to sustain other, hopefully, nonprofit services for my community or other, building a new OR or a new hospital wing. 1999, it was 200% charge to cost ratio. That had doubled. So it's 400% in 2018. That talks about the power of the hospitals over the American health insurers. So we talked about drugs briefly. We're seeing all of these prices going up. And again, I think this is stuff you're familiar with, but this was all happening in the 1990s with deregulation. Strikingly, when you hear people say to you, oh, deregulation makes everything less expensive, it improves efficiency, ain't the case when it comes to healthcare. So again, we spend more than, in fact, 3 times as much as Swedes on per capita on the cost of pharmaceuticals. Jeremiah, you asked about innovation. Is Jeremiah on the call here? Oh, there you are. I'm sorry, Nehemiah. It's interesting. We'll have a whole series of lectures on where new drugs come from and where innovations come from. There's a statistic that is worth bearing in mind. 97% of new molecules, that is new molecular inventions, new drugs that are going to turn into blockbusters or important drugs, they do not come from the pharmaceutical industry anymore. Once upon a time, they did, back in before the 1980s. They no longer do. Only 3% of innovation for actual new molecular entities is coming from the pharmaceutical industry. So that's a question a lot of medical students ask, because you'll hear people say, "Hey, we have a whole lecture on that." Essentially, the prices are translated into all services that we pay for when it comes to healthcare. If you look at MRI, we'll look at some specific issues. I think we have that in the slide to come. Well, I'm sorry, I'm a little mixed up here. What we'll see in future slides is the cost of a CT in the United States. The cost of an MRI is anywhere from 1.5 to 3 times what it is in any other developed nation. We're not doing more of them. We're just paying more for them. Does that make sense in terms of prices? I don't want to belabor issues with market fundamentalism and some of the problems that's set up for us. But I do want to, in improving Medicare, unlike any other nation's administration of a health insurer, it was allowed to not have a single agency supervise the cost of prices. It was the original flaw in Medicare that hospitals and doctors could set the prices themselves. And again, we're going to talk more about Medicare Advantage. In fact, I'm going to skip through that because we're going to have a lot more on that. So, one thing I do need to mention is what happened historically during the 2003 was the passage of Medicare Part D. So as you may have heard, there was no coverage for many things when Medicare was first passed. There was actually no necessity to cover drug costs in 1965. 1975, it wasn't necessary. As the cost of drugs was exploding and new effective medications were starting to become available, it became a necessity. Patients, seniors could no longer afford the cost of medications. It was bipartisan, across the partisan divide. We needed to have coverage for pharmaceutical costs. What was obscured to the public's knowledge was how this was getting negotiated and who is doing the lobbying to create the legislation in Washington. This is important to recognize that Medicare Part D, so the vast majority of drugs are needing to be taken, of course, by seniors. This is in reference to the Medicare program. In 2003, the Medicare drug coverage was set up to be administered and covered by a separate private drug policy bought from a private insurer, for-profit insurer, as mentioned by a pharmacy benefit manager. And we'll talk a lot about that. Each private insurer, by the way, was allowed to have different formularies. So one company could cover omeprazole as a proton pump inhibitor. Another would cover esomeprazole, which is a copycat drug for proton pump inhibitors to cut down on GI issues. etc. So formularies allowed to be different and proprietary. You didn't need to share how you were designing them. They had different deductibles and on the amount of monies expended for the drug coverage. There was a set amount that the drug coverage plan was responsible for. So after you met a deductible, which would variable, the plan would pay some or all of drug costs, but only for the first $3,000. So if you if you were treating cancer, if you're on heart failure and partaking of some new medications, you had a unique disorder or an orphan disease, as one might mention, the drugs would be unaffordable after $3,000, and that would not be an uncommon experience. That was called the donut hole. Even though you have a drug plan, it's no longer covering for drugs. Even though you're hoping to have coverage of catastrophic costs, it gets cut off at $3,000. You would have resumption of that coverage, however, once you get to $5,000. The most important consequence, however, of the Medicare Part D law is that Medicare was prohibited from negotiating with drug makers. The only negotiations that were allowed were between the pharmacy benefit manager, which at that time was essentially an intermediary between the drug coverage plan and the manufacturer. Those negotiations between the pharmacy benefit manager and the drug makers were also opaque. Nobody knew what was going on. Anybody know? So let me ask, I'll just poll you guys. Do you know who wrote the legislation? Or who is instrumental in writing this legislation? Guesses? Do you recognize this guy? Anybody know who that is? That's Alex Azar. He was the head of Health and Human Services under Donald Trump. At the time, he was the CEO of the drug company known as Lilly Corporation. So the pharmaceutical industry was instrumental in doing the lobbying to create the legislation that covered seniors' drug plans. That did not help with the expanding cost of pharmaceuticals in the United States. Anyhow, Danielle, are you still, let's see, thank you. So I'm wondering if we want to make a breakout at this juncture or if we want to move on. What do people want to do? Let's get a consensus. Thoughts? We have an hour. We're going to tackle the ACA.
My preference would be to move on. I don't know that I could make a good argument right now for medical care as a commodity anyway. So I don't know that we've heard enough or to make that argument. So I'd prefer to just move on.
I think that's terrific. All right, fair enough. All right, so let's do so. And take a bio break if you need, by the way. Bottom line, so let's move on. We'll come back to this. And let's head on to the ACA. All right. So basically, the Accountable Care Organization, the Accountable Care Act of 2010 was a creation of the Heritage Foundation. Not many Americans are aware of this. They put forth a position paper in 1989 at a time when they recognized the public wanted universal or expanded health care, suggesting that the private industry could provide universal coverage, have an individual mandate, that is, mandate those who didn't have health insurance to enroll in health insurance, even if they didn't feel they need it, to have refundable tax credits. That might sound familiar when it comes to various public plans of free marketeers, and have a set minimum benefit package. So those were the origins in 1989 of what came to be known first as ObamaCare. My daughter and her family live in Massachusetts, And Romney was the governor of Massachusetts and a popular governor for 8 years. During his administration, they rolled out essentially ObamaCare. And it's been tweaked and such that Massachusetts actually has fairly good coverage for folks in general and for families. The mandate model included ultimately these features. Medicaid would be expanded beyond the federal poverty level. Whereas at the time that this was passed, we talked about CHIP being above 137 federal poverty level. This was Medicaid for all states, and initially was mandatory for all states, was to expand who got covered based on their income level to 137% of federal poverty level. In 2012, unfortunately, that component of it was felt by the Supreme Court to not be explicit and was because of tax funding mechanisms was felt to be optional. So as we contend with that issue to this day. The other elements of this mandate model of reform is there would be tax credits for those whose income were between 138 to 400% of federal poverty level. Again, it was touted as universal. It's actually not universal, but it does expand it to more people who have lower incomes. But so basically, a tax credit for people who aren't paying taxes because they don't make enough income, that's kind of bizarre. But that was the conception of providing credits for low earners, but by taking what would have been the tax from that person and pay it to private insurers. Does that blow your mind? So, in other words, if you make 400% of the federal poverty level, you might have zero taxes, but they would take what an average person might have paid in taxes and give that not back to the family to take care of their kids' health, food costs, but to the insurer. That's a striking reallocation of federal taxes. But that is part of the model. There was also using subsidies for those who would otherwise be interested in purchasing ObamaCare in this instance, if you like, to help maintain their premiums. So it would be a buy-in. And this would be run by state-run insurance exchanges. The other important take-home message is insurers had to use community rating. You needed to not do actuarial rating in setting premium prices. Am I obscure? Are you looking at my screen, by the way, in front of? Yeah, I'm sorry. I did not get enough sleep last night. Sorry about that. Public option. Again, was passed in 2009 by the House initially. And then it went to the Senate. The public option, as I think I mentioned the other day, was part of the initial ACA. Max Baucus, who is the Democratic head of the Finance Committee, cut it out because he did, and I think they felt it would not pass if it was maintained as an alternative. Do people know what the public option is? People familiar with all right. Public option is offering Medicare to those less than age 65 as an alternative to employee-sponsored insurers. That's what the public option is. Okay, it's basically expansion of Medicare to those less than 65. It could be if you're age 35. as an alternative option. I want to pay my premium to Medicare instead of paying it to United Health or Aetna or whatnot. That would be a striking sea change, and you could be sure that the American health insurance programs do not want that to ever pass, because there's going to be a sucking sound of people leaving one form of insurance to another. But that was initially actually part of the ACA as passed in the typically more progressive House. It was cut out from the ultimate legislation. Again, as we mentioned, 2020, this came around again, and you're going to see it once more. It's not going to be the last time you see it. This is if you wanted to watch this, you could see, I'm not going to spend time today on this. There are a number of advocates, including from Physicians for National Health Program, who went to the meeting where the finance committee was being held at a long dais table. There are about 20 stakeholders. Physicians for National Health Program was not one of them. So in any case, what ultimately passed as part of the ACA were some important changes. The ACA did legislate that pre-existing conditions could not be used to deny insurance or to prevent coverage for those medical conditions. As I mentioned with my patient with diabetes the other day, his diabetes was not covered, even though he'd paid premiums for 20 years. It was a pre-existing condition. So you can get insurance, but it wouldn't cover your cancer from previous years, your hypertension, or a variety of other issues. That's a crazy form of insurance. That was eliminated. The other important issue that you probably may have experienced is coverage was maintained for children less than age 26. So if you're in college, if you're in professional school, your parents can actually continue to keep you on their plan. There's also the prohibited limitations on maximum coverage amounts for a particular illness. So that is genuine insurance. It would cover catastrophic costs. You might not be aware of this, or there are also incentives to improve hospital safety, which actually made some real impact in terms of hospital care. There was incentives and payments for primary care docs to coordinate the care of their patient once they left the hospital. Again, in thinking about a non-health system, there's nobody minding the store in terms of an agency in Washington. You've got health insurers, you've got hospitals, you've got clinicians, but you have nobody who's maintaining how many residency slots there are or how many primary care docs are going to underserved communities. It's all state-run or not run at all. So until this, hospitals actually got paid more for taking care of a knee infection after a knee replacement. If you did or a complication of a surgical infection, or not going over the medicines that your patient with diabetes is supposed to be on after you've started insulin simply during their hospital course. Okay, they go home, they can go back on their oral hypoglycemics or the GLP-1 agonists or their SGLT inhibitors, whatever it might be. During the hospital, oh no, they needed to get insulin because of their surgery or because of their sepsis or whatnot. You're going home, nobody was minding the store. Who's coordinating that transition of care? So this is, I think, an important aspect of the AC that you might not have heard about, but that was built in. There's also limitations on profits by insurers. That is a 64-year-old, they're not old enough to be able to get onto Medicare, could not be charged more than 3 times what would be charged a 20-year-old. Previously, they were using medical underwriting. Again, we discussed this. What provided the insurance to folks was the private markets, as provided in each state in a state exchange, in a marketplace. By the way, the other thing that was instrumental and essential was the ACA provided 10 essential benefits. Insurers might or might not have provided these benefits in years past. They are now required to do so. This is employee-sponsored insurers. They have to cover all ambulatory services, emergency services, hospitalization, and surgery. That's most did already. They didn't have to previously cover pregnancy, maternity, and newborn care. They did at this juncture. Mental health, substance abuse services, including psychotherapy, prescription drugs. I remember Medicare Part D is just for those age 65 and older. Now the insurers did have to cover prescription drugs for employee-sponsored insurance. Rehab services, laboratory services, and really quite important is preventive and wellness services. Previously, it was carved out. You didn't, a colonoscopy may not be covered. Mammography may not be covered. Certainly a CT scan for a heavy smoker after 20 pack years of smoking, if you're 45 or 64, would not be covered. These preventative measures were now built in to the American health insurance systems, finally. Oral and vision care for children, but no dental or vision care for adults. Again, we talked about this yesterday. The rollout was a disaster, done by computer with the systems going down and crashing recurrently. So those are the features of the ACA. Any questions about that? So
actually,
yes,
sorry, I had a
please.
quick question.
Sure.
So you mentioned that it's like run by like state exchanges. What are state exchanges, and like how
Yes.
is it different if it's run by a state versus if it's like federal exchange, I guess?
It's very different. It's very different. So you're familiar with Medicaid being run by a state.
Yeah.
Medicaid essentially is a pan-state agency for all of its citizens, where the state government will fund insurance if you meet what sometimes is onerous requirements, but if you meet their requirements, certain income level, are you seeking a job in some states, right? Whether you have children or not, eligibility differs, but there's an administration, typically Department of Health and Human Services or some other agency within a state, that is the ultimate funder and manager to a state manager of Medicaid. What has happened is so the distinctions are interesting. Managed care private organizations, could be United Health, for instance, are now contracted by the Medicaid state agency to administer that Medicaid. All right. Back before the deregulation, 1980, 1990, almost every state was doing their own state administration of Medicaid. Remember, the funding, 50% comes from state taxes, 50% comes from federal taxes. So if I am just late, if I am poor and I have a child and I'm disabled or whatnot, I'll be eligible for Medicaid. All right. I apply through the state, but it's actually through one of these state managed care organizations. Right. So that's what Medicaid looks like. The marketplaces are basically federally supported programs providing those who are above the eligibility level for Medicaid with an option to purchase less expensive insurance. So the ACA did a couple of things. It's going to be on the next slide. One of the most important impacts of the Affordable Care Act is it expanded that eligibility of who is eligible to receive Medicaid, right? So that's a lot of folks who now have, but for those who are not eligible, between 137 to 400% of the federal poverty level who couldn't be getting onto Medicaid, you now had tax credits being paid to private corporations, United Healthcare, Aetna, Cigna, et cetera, to decrease the cost of your premiums, to make it more affordable. And so again, it's a wacky system. Talk about efficiency, or would you ever dream up of such a system unless it was designed to provide profit to the to health insurers? No. You design something like Medicare, which is simplified. But so you have a state marketplace. So let's say I'm in a gig. Let's say I'm designing my own software, and I was working for a large employer. Now I'm self-employed, and I'm trying to afford insurance for my family. All right. So I'll go to a site that the state puts up, where I could find three, or hopefully three, competing private insurers offering health insurance to me now through the marketplace. Remember, most Americans get their insurance through their employer. I don't have an employer who's doing that. Where do I go? So I'm going to go to the marketplace. It's not Medicaid. So you have three different insurers, and I'm going to look up each insurer's benefits and programs. All right. There's going to be a uniformity of how much it's going to cost, but they'll have a bronze, a silver, and a platinum plan. And any of you guys have on Obamacare right now? A lot of students are. So basically, I have these three options to purchase one of these different plans. That makes sense? The state is actually, the insurance agency of the state is making sure that everything's up and is above board, but they're not running it. All right, they're offering it. The federal government is making that premium more affordable for me by taking a tax credit that would normally go to me and sending it to them. Does that make sense? So it's very complicated, and it's called state marketplaces. So this slide may answer that a little bit better. So these are the biggest effects of Medicaid. In all states, if you qualifying for traditional Medicaid is based on eligibility issues. In the states that expanded Medicaid coverage, it is expanded to 138%. If you make income below that, you qualify. These premium tax credits go to those between 100 and 400% of the federal poverty level. They get paid to the insurer who put up their insurance in the health marketplaces. And adults in states who have not had ACA expansion with incomes below 100% of poverty level and don't qualify for Medicaid in those states, by the way, don't have any take home from the ACA. They fall in a gap. It's a little small gap because their income range is below that that is available to them on the marketplace, but they're not eligible for Medicaid. And that's about 2 million people. There's now legislation that's starting to address that. So how did the ACA work in terms of covering people in the gig economy, covering people who could not afford health insurance otherwise, covering people whose income was quite low and could not afford insurance? The answer is yes. This is around the time that the ACA, this is a whole series of changes that happened during this decade. So the ACA was signed into law in 2010. The exchanges opened in around 2013. I remember that October. It was a disaster. The individual mandate, which was initially part of it, which was that if you did not have health insurance, we want to help decrease the premiums for everybody. You got to put in. That started a few months after that. The states individually expanded Medicaid on an ongoing basis, and then it plateaued. A lot of states, actually southern states, for the most part, and some red states, I would say, based on politics, decided not to expand the ACA. And then, politics being as they are, Trump was elected in 2016. During this period, you see a dramatic fall off in the number of uninsured. There were, as we will see, a host of different measures passed by a conservative Congress to try to cripple the ACA. But here you've got just another slide looking at the millions of Americans who were uninsured. It dropped from nearly 40 million Americans to about 22 million Americans. The pandemic, and we'll talk about that as well, played a role with Medicaid coverage as well. Again, in terms of those who had employer-based health coverage was dropping between 98 and 2018. And this is a chart looking at the percentage of those who are not on Medicare enrolled in employee-sponsored coverage based on their income. So remember, this is just another way of looking at what happened to the economy and the legacy corporations no longer being available to cover insurance for employees. Those folks who are making, in 1998, there wasn't that much difference between people making low incomes and people making high incomes. So if you're on 100% of federal poverty level, in between 98 and 2008, there wasn't a great loss of health insurance. But if you look at people who are above federal poverty level, they may be in the gig economy. They're not making a lot, but they don't have health insurance through their employer. Those folks are losing their health insurance during that decade. Does that make sense? And folks who are doing well off, no change. They still had health insurance regardless. The folks who are down here are the folks who are able to take advantage of the ACA. In case you're wondering how the ACA is financed, let's see, what time is it? I'm sort of on slow gear today. I guess we're doing okay. The financing of the ACA was in part the premiums coming from well-off young people, the individual mandate. There was a mandate and remains a mandate for those businesses that employ more than 50 employees to chip in towards coverage of health insurance. Remember, before and this is not through the marketplace. If you had 50 employees before 2012, you didn't have to provide health coverage. If you had more than 50 employees, now you did. You had to provide insurance-sponsored insurance, employee-sponsored insurance. Those who did not buy in with an individual mandate or as an employer had paid a penalty. How else was this paid for? There was a almost 4% tax on capital gains and dividends. That's not income of the wealthy, but where a lot of the wealthy accrue a lot of their wealth. And there was almost a 1% increase in the Medicare Part A tax rate for high income taxpayers. You may not be aware of this, but if you make the big bucks, you pay more for Medicare, which is a good thing. There's also an excise tax for those who could afford expensive Cadillac health insurances. There was an excise tax on that. Lastly, some of the funding came from big pharma and medical device manufacturers, as well as health insurers. And there was a cap on tax deductions for CEO pay. So the good effects of the ACA is almost 50 million American citizens of 50 million Americans who did not have health insurance, 25 million of those were able to now get funded. Unfortunately, we still have a growing number of functionally uninsured. The ACA is not a cure-all, but it did have impact. Here's some more information for Hamza about marketplace plans. They're standardized. They have these three different, actually, I forgot about gold, bronze, silver, gold, and platinum plans. The lowest premium plans, the bronze plans, have a higher deductibles, higher out-of-pocket costs, whereas you have the lowest deductibles, as you might guess, with the platinum plans, but the highest premiums. They're what are called catastrophic plans or skinny plans. Was also abolished by the ACA. That's important too. I had one patient with scleroderma who had recurrent bowel obstructions, who had taken out these plans that were only worth the cost of the paper they were written on. They provided really no, there are so many exceptions with pre-existing conditions and carve-outs that, yeah, you could afford having a plan, but it really did nothing for you. It did a lot for the insurer. They were outlawed by the ACA but they were reintroduced during the Trump administration. Again, premium tax credit is based on a capped amount that a family would spend otherwise on payment for health insurance. And the cap depends on their income. Lower income families having a lower cap and higher incomes having a higher cap in terms of how much tax credit would be provided. And this is a little complicated. Maybe this, so this shows maximum percentage of income if you're going to go on a silver plan. If you're making over 407%, there is no cap on that. And if you're making under 100%, there's no cap. There's a gradated cap in between. Should I go through this, or is this sort of arcane? I'll try to tackle this. So here's an example. Here's somebody who his income is at 250%. So I'm Pat, and I estimate that my income will be $32,000 per year. I will seek a silver plan. It'll cost me $500 per month. So I'm not on Medicaid. With the ACA, with that income, I would have a cap of 8% of that income to go towards that silver plan. That means that I would not pay more than $221 per month over the course of a year. And that would be considered a tax credit of $279 per month. And that goes towards a discount and gets paid to the insurer. It's complicated, I'm sorry. Did we see a decline in bankruptcies during this time? Yes. There was a modest decline. By the way, if you guys are on GoFundMe, you see that that's the #1 reason that people still are trying to get insurance from one's peers, so coverage for things. But there was a drop. This is, again, another way of looking at how many Americans were facing medical debt. There was a significant drop-off as a consequence of the ACA. But there's still 44 million Americans who face financial catastrophe by medical debt. Only place on earth. Let's see. Given corporate special interest on legislation and rising public dissatisfaction. So I think maybe we'll just push on. Does that make sense? Yeah. What happened historically after the passage of the ACA? There was the Tea Party. There was Palin and McCain ran for president against the ACA as being overreached by government, despite this coming from the Heritage Foundation. A lot of misinformation. And here's a great, I love this cartoon. Here's ObamaCare, Mitt Romney running for president now. Your kid is ugly. And he loved ObamaCare in Massachusetts. And here's Obama with his child. They look identical. But this was the reality of what we were dealing with in politics at the time. So politically, the Tea Party was railing against this as a rallying cry for the right. What was happening with the private insurers? Well, they were making out like a bundle. Their profits went up. That's not a surprise. They were instrumental in doing some of the lobbying to create the legislation. In fact, they were setting records as a consequence of the ACA. This is before the passage of the ACA. You choose the insurer. Here's Humana. This is $1.1 billion, whereas they're making a third of that or less in 2000. That holds true for all the private insurers. The other thing that was happening simultaneous with this. So you have deductibles that were set to an extent under the ACA. But remember, employee-sponsored insurers could still market and did not have restrictions on deductibles or coinsurance. There are a lot of restrictions being made on them. They have to now cover pre-existing conditions. They have to now cover colonoscopies and mammography and a lot of other things. But the legislation did not restrict those things that they could maintain their profit by. So they basically boosted them. So here's the spending on deductibles by Americans between 2014 and thereafter. This number has plateaued a little bit, but it went up substantially, 256% compared to spending on co-payments, for instance, which had plateaued dramatically. The insurers had realized that they could maintain profitability by inventing coinsurance, inventing deductibles. This is the amount of expenditure that insurers were putting out towards medical loss during that time. Compare that to the amount that they're asking in deductibles. So here's another example of what was happening during this time and still to today, whereas premiums and deductibles have risen much higher than the wages that one earns. So here's a worker's earnings up to 2020. Here's how much one was having to pay in deductibles. And this is that inevitable climb in the yearly premiums for that insurance. Here's overall inflation. I think you may be talking about deductibles at a later point, but I am going to tackle that just briefly here because it's important to recognize. There's a reason people that insurance companies create deductibles. The theory proposed is that in a competitive free market, if you have a high deductible and higher copays, it'll lead patients to seek services which have the highest quality and the lowest cost. So if you are a consumer, quote unquote, in the realm of insurance, you've got skin in the game now, whereas otherwise you wouldn't care because your insurance company is already paid to do this. But in reality, again, what we pay for a refrigerator looks a lot different than when you're going to an emergency room to get treatment for passing your kidney stone. Or when your doctor tells you this is the surgeon I recommend is the doctor who's best for taking care of your cancer or your vascular surgery or whatnot. Those prices where that's going to happen, despite federal legislation, remain non-transparent, and they're certainly not competitive. So yeah, this is the theory in any other free market system that would apply, but it doesn't apply in healthcare. Do people get less healthcare? Yeah. The theory works for the insurance company's profit. Folks covered by high deductibles do spend less on healthcare, but they don't discriminate about where they're spending those dollars, but on what their paycheck may have looked like that month and how much they're paying on their credit card expenses. So they forego a lot of preventative care, or they delay some essential care because they have to make choices between putting food on the table versus expending something for a health need that they may not recognize as a major need. So health deductibles do work to lower healthcare's medical loss, but they don't ultimately lower health costs by improving treatments or reducing care for diseases. And they certainly do nothing to improve care. 2016, Trump Care. Here's a great, this is from the National Health Service proponents on a street in Britain. This is 2015, and I love this sign. Universal healthcare, keep your hands off of our NHS. The Brits, even now with all of its struggles by conservative parties to ratchet it down, still love the NHS in the general sense. What were the measures during the 2016 to 2020? As we talked about, the Supreme Court ruled that it was unconstitutionally coercive to, based on the legislation, to mandate that every state expand Medicaid to 137% of poverty levels. It became voluntary. So initial feds can withhold. Oh yeah, that was the penalty that the feds would make. That if a state did not expand Medicaid, they would withhold the Medicaid dollars to that state. That was ruled unconstitutional. They repealed, as mentioned, the individual mandate. It was previously a tax penalty. And some people might ask, how many of you have read yet enough Huey Reinhardt to read about death spirals? If you have if you are offering an insurance via community rating, remember, you need a lot of healthy people to keep premiums low because 20% of your folks are going to be getting heart transplants or, expensive surgical intervention. Does that make sense? You need to keep the overall funding for a big kitty high enough that you can keep premiums low for everybody, but still pay for expensive care, right? So the individual mandate was to assure that healthy young Americans would pay something of their premiums to help cover those folks who are going to need health care at a high amount. So the folks who repealed the individual mandate thought that, oh, that's going to be the death knell of Obamacare. The cost of those premiums by the folks in the individual marketplace is going to explode. Of interest, they didn't. And one of the reasons they didn't was because the feds could still control costs to an extent and control how much profit was being made by the private insurers. Built into the ACA was a percentage of profit to be taken from the premium. So basically, there was a federal process of a single payer saying, no, you're going to have to adjust your premiums so you're still expending this much on medical cost ratios. So as a way to buy, and it's interesting, a lot of people predicted the end of the ACA when the individual mandate was outlawed. Did not come to pass. And there had to be some adjustments made. But if you're a federal agency, you can do that and maintain healthcare. In any case, the funding of the individual mandate occurred. A lot of other things ensued. The excise tax on Cadillac insurance was repealed, and they allowed skinny plans to be reintroduced. There was a repeal of cost-sharing subsidies to insurers to continue to offer their product in a state's marketplace. Well, we've seen a lot of discussion about states expanding services to their population. I mentioned to you folks who fell in the gap. They were working, but they could not get Medicaid in the state of Texas and had catastrophic health complications that were purely preventable as a consequence. This still remains the case in the United States. But each year, one more state is having pressure on it to get beyond the politics and actually help people. And in this case, you see that Mississippi, as of this past April, agreed to expand Medicaid under the ACA if they get a waiver to continue to use a certain eligibility criteria based on how many hours you're looking to find work. But for the most part, a lot of Oklahoma, Nebraska, the Dakotas, a lot of states have expanded the ACA because it helps cover folks' care. Again, a lot of people are left between the cracks. Certainly undocumented immigrants, seniors requiring long-term care, folks who really can't afford to continue healthcare because of high deductibles. There's a lot of Americans who aren't realizing they're eligible, not just for Obamacare, but for Medicaid. I see them in my clinic, in the free clinic. They didn't realize it, and they may have political reasons not to want to take avail of it. So what was proposed, by the way, during the Trump years? Not much. This was the Graham-Cassidy reconciliation. Basically, the changes would be to the ACA. It would eliminate most of its stuff. It would eliminate Medicaid expansion, eliminate subsidies for out-of-pocket provision of folks in the gig economy and the tax credits. This was successfully eliminated. It would eliminate employers from having to provide care for their employees. It would change a variety of other things. It was really not going to be tenable. Then along came COVID. And COVID actually changed, as you might know, in your lifetimes, what healthcare looked like in the United States. All of a sudden, insurers no longer had to worry about medical loss ratios. The hospitals had to worry about filling their beds. Nobody was coming in to get healthcare. Everybody was deathly afraid of getting COVID. And all those elective colonoscopies, those elective hernia repairs, those elective procedures were no longer happening. A lot of those lucrative procedures, those knee replacements, were getting scheduled out 6 months because the operating room was converted to a room to house folks who were treating for COVID. And that was a reality. I saw that. It was a topsy-turvy time in the American health industry. But health insurers didn't have to pay out much. Remember that provision that health insurers have to expend a certain amount of their revenue on the ACA towards health outlays, medical loss. As a consequence of interest, the year after COVID, around 2022, they were paying people back and lowering their premiums to make up for the fact that there was little expenditure. So this was, again, there were ways to design this. That was an interesting phenomenon a lot of people are not aware of. The other thing that ensued during the pandemic is folks who are on Medicaid were allowed to keep their Medicaid. Eligibility rules flew out the window. And as a consequence, people come into Medicaid, then they come out of Medicaid. A lot of the right-wing disparity of Medicaid is not borne out in facts. A lot of people who are on Medicaid for a time in their lives go on to be, affording all sorts of things, including affording paying taxes for other people on Medicaid, because they get gainful employment, they get out of a hole, or a variety of other issues. So there's ingress and outgress from Medicaid all the time. What happened with the pandemic is people held on to their Medicaid during those years. And so it was the lowest percentage of people who are uninsured in probably 50 years, around 8%. The other things that the Families First Corona Response Act, it mandated that employers provide sick time and actually family leave time if a employee was suffering with COVID. So that was also something that happened during the pandemic. With the election in 2020 of a Democratic Congress and president, a lot of things happened that people may not be aware of. You'll see this again, but I am going to touch on it briefly in the next few minutes. Insulin prices had been climbing exponentially between the 1990s and mid-2000s and 2019. And that was in sync. This is a drug cartel if I've ever seen one. Each one of these manufacturers, Sanofi and Lilly and the like, all were raising their prices in link with one another. There is an FTC there. I think they're finally getting some teeth back. But so people were disgusted by that. Finally, legislation was passed to put a cap on the cost of health insurance. This is just a cartoon about, this is John T. Q. Public reading about the cost of insulin being $240 a bottle. And the big pharmaceutical lobbyists saying, you think that's expensive? I'm having to spend $26 million to lobby against any drug reforms. So basically, outrage resulted in change. The Inflation Reduction Act set the cost of a vial of insulin to $35 a month. And by the way, just by setting that, the drug makers voluntarily lowered their costs, lo and behold, to $35 a month. Isn't that interesting? And a number of other drug programs are instituted, which I'll discuss when we do pharmaceuticals. There were caps and adjustments, changes to Medicare Part D. But the most important change that happened, that's not spoken about that often with the Inflation Reduction Act, is that the federal government could negotiate now prices for drugs. Not for all drugs, alas, but for a substantial cost of drugs among the high expenditure and important pharmaceuticals, things that you're learning to prescribe currently. And that'll take, there'll be a future talk on this. So again, lots of reasons that costs have continued to climb despite the ACA. Lots of reasons that we remain an outlier. Lots of reasons that Americans are still going bankrupt and suffering with trying to deal with the hassle of maintaining health insurance. One of the things that Dr. Singh may have alluded to, and I think it would be important when you're doing your international analyses, what does it look like for a person to try to get health insurance in another country? What does that process look like? How much of a burden is it for them? Not just financially, but how much time are they spending to try to find a drug plan or to try to find an insurance plan? Or what are they worried about when a family member becomes ill? So we saw some Band-Aids inserted, usually with the acquiescence of private industry. But in looking at health systems and talking with your patients, talking with your peers, talking again with fellow physicians, these things are worth bearing in mind. Sorry, I'm a little discombobulated today. And I think this talk was a little discombobulated. I hope you got something out of it and some appreciation for what was happening when the ACA was instituted. Questions? Looks like some folks have dropped off. I'll take responsibility for that. But what questions might you have about this? Yeah. Who's got some? You want to share what you got in the chat? Is that from?
Yeah, that was just me. I'm looking at this as a way to educate myself, like, and so I'm asking or I'm saying the things I'm thinking. And again, let me just apologize up front, and I won't. It's I think I sometimes speak in a manner that is more appropriate for attorneys, and is not necessarily the same way that other people or other organizations would talk to one another. And so I apologize up front, and please feel free to call me out on it. But so anyway, with regards to this learning, I just like to throw out, these are the thoughts I'm having right now. So somebody can say, yeah, Chris, by the way, you can attack anything I say, because actually that's how I learned. So by all means, go and say, Chris, that doesn't make any sense. And so, yeah, I was just throwing out there, I do think it's a valuable, like I would love to, and you don't have to do it, I can do it on my own. I'd love to go through the marketplace and actually see what that means. Like actually somebody pull up, or I'll pull up the marketplace, because, and I probably have more experience than a lot of us interns here right now in that, but I have insurance, but it's provided through the military. I still pay a small amount, though it was arguably supposed to be free when I joined the military forever. But it's not the same insurance that my daughter or my son has. It's not the same insurance you guys have. And so I would love to see what the marketplace actually looks like if I go through it. I would, and I would love to be able to appeal to veterans, to conservatives. And I think there's a great argument for all of those. But I also, as I allude to, is I don't know the efficacy of it, right? Like, I mean, ultimately, are you better off just assembling your 51%? You get the president, you get the two things, and you just push it down people's throat to get what you think is right, and you've got the majority at that time? Or is it better off, or is it possible to get a broader consensus to where both sides are like, oh, you know what, there's a value here, and we get across? Just practically speaking, I can see the argument for both sides, but if it feels better if it's a consensus, and I think there's arguments that can be made to those conservatives.
Sure. And I think your point about having consensus to create reform comes to an incremental approach to making change versus a more radical approach. It's going to have to be, I think, given the American experience, incremental. But be that as it may, in terms of seeking, clearly we're going to have to seek politicians' consensus. There's actually a majority already among Americans, and I didn't show the Gallup polls or more recent polls, that consensus sort of already exists. But let me give you something that's really interesting. You wondered about applying for a marketplace. I did that. So I'm on Medicare. I've been on Medicare for a while. But I elected to pose myself as a 35-year-old without a family, non-smoker, calling to get health insurance via the marketplace. Now, I'm trying to remember how I did this. I think I actually called a broker. So there are brokers. There are systems of that people make a living selling insurance in the United States. So I contacted a broker and said, "Hey, I'm interested in getting, ObamaCare insurance. How much would this cost?" I might advise you against doing that unless you give them an alternative phone number. At the time, I had a landline and a cell phone. I had to get rid of the landline because it would not stop ringing. And if you think about that, if people are working that hard to reach somebody's making a lot of dollars to make that happen. So I would continually get these calls from folks selling me their bronze plan or their premium plan. And of interest, I spoke with one broker and say, "Hey, I don't want to pay for somebody else's OB care. I don't have a family. I'm not married. Why would I want to do that?" It was during the Trump years. She was able to say, "Oh, we now have available a skinny plan. So you don't have to pay for anybody else's care." Of course, if you look in the details, and it is worth looking in the details of these things, it would have been worthless. Maybe it would have covered something, but if I had catastrophic needs, which is the only reason a young person might want care to some extent, but I would have been in the hole. So anyhow, no, I think that's a terrific exercise. My daughters at one point had to do that exercise and they hated it. And it was also not that unaffordable. Some of these plans are not that cheap. And right now, the average American is spending about the cost of healthcare is about a third of one's income. That's extraordinary. When I was growing up, you never wanted to spend more than a third on your housing. Oh, God knows that's changed. But so there's the way that this impacts the people it's not just the hassle of trying to get on the marketplace, but their pocketbooks certainly as well. So those are important points, though. Yeah. Other questions about historical events or otherwise? Yes, Kaya.
I have a question about sort of like pharmaceutical companies and other insurance companies backing politicians. I know you mentioned about it earlier, how it's kind of a consolidation of power about these politicians wanting sponsorships or keep their power and carry that on. And I know in the past with like a lot of pharmaceutical issues with like lowering the cost for treatments and other drugs, that has been a challenge because of these pharmaceutical companies and their political backings. Is there a way or like an event that has happened in the past couple of years where we've made significant progress against that? Or I guess I'm just kind of curious.
Sure. Thank you. So, actually, Dr. Singh mentioned the issue of power with politicians, and I like to think of my my congressional representative or my congressional senator as corporations, because the amount of money in politics, which has been, allowed by the Supreme Court with the Citizens United. There's a lot of invisible dollars that are now going towards PACs and towards election and campaign finances. And a lot, and your representative from your state has basically about 3 months to spend in Congress before they have to start worrying and spending all their time raising their finances for their next election. Okay? It's nuts. So they're corporations. They are basically bringing in dollars to fund their next campaign. Does that make sense? There's anybody see Michael Moore's sick? It's called a Sicko. It's a movie, um, and it's this great flick that shows your congressional representatives with little bubbles over their heads of how much they receive from the pharmaceutical industry on a yearly basis. It's called Sicko. It's really worth seeing. The amount of money is expended by the pharmaceutical industry for each politician is extraordinary. Having said that, your representative is your representative. They go into politics for a reason. It's not just power. And usually they do care about their constituents. And they understand, and it depends on the politician, but they are beholden to their constituents in a lot of ways, morally as well as politically. So I think for the most part, people will see the world through their own particular filter. But that filter, for instance, with the cost of insulin, even if you're a free marketeer, you're going to recognize that things are wrong. And there was enough votes when there was a blue majority to pass the Inflation Reduction Act, which now sets caps on the cost of insulin. And now is each year there'll be about 15 drugs that the manufacturer will have to negotiate with Washington, D.C. as to how much it's going to cost. That is a sea change. Again, I don't think a lot of people recognize. That didn't happen by accident. That was advocacy from many different stakeholders, from hospitals, in part from insurers. Insurers didn't necessarily, the pharmacy benefit managers, which we'll talk about, that's an intermediary. Intermediaries don't want other people getting into the act. They were not supportive of it. Pharmaceutical industry was not supportive of the Inflation Reduction Act. But we now have a foot in the door, 15 expensive drugs each year will have to negotiate with Medicare for their cost. And by the way, what does that look like in other countries? If every other industrial country has been doing this for decades. If there are 3 manufacturers, for instance, of a anticoagulant, a novel oral anticoagulant, you've got Eliquis, you've got Pradaxa, Xarelto. Those are the brand names of Apixaban and the various agents. They will need to go to the government saying, this is how much I think that we're worth. Well, your competitor, we can get at this price. So they'll play one off against the other. And the benefit to my patient is the Apixaban only lasts 12 hours. I can start and stop that a lot more effectively than I can with Rocaltrol. You're charging too much for this because I think this is a better drug. There's lots of ways that a federal agency that is minding the store can lower efficiently the cost of drugs. And as we'll talk about, that would not have prevented the invention of any 3 of those drugs, by the way. They came from academia. They came from the startups that circle academic programs to create these things these days. I don't know, is that off the base or does that answer some of your questions?
No, it was very enlightening. Thank you.
Sure. Yeah. Other questions? All right. Well, and again, this is not the first time you're going to be hearing some of these things. It's interesting. In getting back to reaching consensus, it's striking. A lot of the consensus is not on what's rational. if you take a majority of Americans, let's use gun control as an example, or violence reduction when it comes to weapons. It's common sense that a gun stock that's firing as rapidly as a machine gun should be outlawed in the same fashion. But because of the interests of private corporations, the dollars that we expend in politics prevents what seems to be rational from coming to pass. And I think because politicians are now corporations of their own rights that are competing for those dollars, a lot of what should be passed as common sense legislation in the health realms as well does not. Not because there isn't obvious consensus from what makes sense, but because of power politics and finances. So that's where what we contend with in creating reform in any industry or reform in any segment of the American society. So sorry, and we'll see changes. This will pendulum swing throughout our lifetimes. And hopefully we're moving back towards a righting of that pendulum.